Okay, so good afternoon, doctors. So for today, I will be discussing two topics. My first topic is about ACTH, or adrenocorticotropic hormone deficiency, and my second topic is about Cushing's disease. So for my first topic, which is about ACTH deficiency, my objectives are as follows. So first is to discuss the consequences and clinical presentation of ACTH deficiency or secondary adrenal insufficiency. Second is to differentiate hypocortisolism secondary to pituitary failure and that which is secondary to primary adrenal failure. So I will not dwell with regards to the primary and tertiary adrenal insufficiency, as there will be a separate didactics for those topics. But in this presentation, I will try to highlight the important differences between primary versus secondary versus tertiary adrenal insufficiency. And third is to discuss the approach to diagnosis and treatment of ACTH deficiency. So in order for us to better understand the next few slides, let us first have a quick review on the HPA axis. So the HPA axis is composed of the hypothalamus, the anterior pituitary, and the adrenal cortex. So the hypothalamus produces CRH, or corticotropin releasing hormone, which stimulates the anterior pituitary to produce adrenocorticotropic hormone, or ACTH. ACTH in turn stimulates the adrenal cortex to produce cortisol, which is the ultimate product of the entire HPA axis, and cortisol, which is also the primary stress hormone of the body. Now, in the presence of elevated cortisol levels actually exerts a negative feedback effect on both the anterior pituitary as well as the hypothalamus, so, in order to prevent further increases in cortisol levels. So should there be a decrease in cortisol levels due to problems intrinsic to the adrenal cortex itself, we call that primary adrenal insufficiency. So most probably it's due to autoimmune destruction of the adrenal cortical parenchyma. Now, if there is a decrease in cortisol levels as a result of decreased stimulation due to decreased levels of ACTH, then that's what we call secondary adrenal insufficiency, wherein the defect is already on the anterior pituitary. Now, if there is a decrease in cortisol due to decrease in ACTH, which is ultimately due to a decrease in CRH, or corticotropin releasing hormone, that's already what we call as tertiary adrenal insufficiency, wherein the defect is already as high as the hypothalamic level. So meaning to say, by saying ACTH deficiency, then we're talking about secondary adrenal insufficiency, which is the focus of our discussion for today. So the causes of secondary adrenal insufficiency are as follows: glucocorticoid withdrawal after treatment-associated suppression of HPA axis, which is actually the most common. Next is isolated ACTH deficiency following surgical resection of an ACTH secreting pituitary adenoma, mass effects of other pituitary or cellular tumors, pituitary irradiation, pituitary apoplexy or hemorrhage, as mentioned earlier by Dr. Marabiles, and congenital isolated ACTH deficiency. Now, for the clinical presentation, of course, all adrenal insufficiency, all types of adrenal insufficiency would present with hypocortisolism. So by hypocortisolism, there should be malaise and fatigue, anorexia, weight loss, GI disturbance in the form of nausea and vomiting, and of course, there would be hypoglycemia. Now, it is important to note that there would be secondary adrenal insufficiency is not accompanied by hyperpigmentation, and there would be no features of mineralocorticoid deficiency, because we can only see these two in primary adrenal insufficiency. Now, the reason for that is this slide. So this slide shows the differences between primary versus secondary versus tertiary adrenal insufficiency. The ones highlighted in red and in bold letters are actually the major defects in each of the different type of adrenal insufficiency. So for primary adrenal insufficiency, the major defects are there would be decrease in adrenal production of cortisol. There is a decrease in production of aldosterone, and there is also decrease of androgens. So meaning to say, all three hormones produced by the adrenal cortex are all decreased. Now, the reason for that The reason for that is due to the autoimmune adrenalitis, wherein there is autoimmune destruction of the adrenal cortical parenchyma. So in primary adrenal insufficiency, there would also be increase in ACTH as well as increase in CRH in an attempt to increase the production of cortisol. But again, since the adrenal glands are already destroyed, there is a decrease in cortisol production. Now, in primary adrenal insufficiency, it's important to note that there would be hypotension and there would be hyperpigmentation. So the hypotension is due to the decrease in aldosterone, because recall that the effect of aldosterone is to increase sodium reabsorption. Sodium reabsorption. So the effect of aldosterone is to do increase sodium reabsorption. So in the event that there would be decrease in production of aldosterone, meaning to say that there would be decrease in sodium reabsorption, thus there would be hypotension. So because aldosterone plays an important role in salt and water balance. Next, there would be hyperpigmentation also because of the effect of ACTH on the dermal melanocytes. So the ACTH act on melanocortin receptor 1, melanocortin 1 receptors to stimulate production of melanin by the dermal melanocytes. Now, with regards to secondary adrenal insufficiency, there would be a decrease in ACTH, which is the primary defect. And as a result of that, there would be decrease in production of cortisol. So of course, CRH would increase as an attempt to increase the production of ACTH. Aldosterone. Sorry. So aldosterone would be normal in secondary adrenal insufficiency because aldosterone production is not affected, while there would be a decrease in production of the androgens. So the reason for the decrease in androgen production is this one. So going back to the adrenocortical hormone biosynthesis, wherein we have from cholesterol, we are able to produce aldosterone, then we are able to produce cortisol and the sex hormones or DHEA. So under the action or influence of ACTH, we are able to produce cortisol as well as the DHEA or the sex hormone or the androgens. Now, aldosterone, on the other hand, is regulated independently by angiotensin 2. So meaning to say, if there is decrease in ACTH, there will be decrease in production of cortisol, and there would also be decrease in production of the androgens. Thus, we have decrease in androgens in secondary adrenal insufficiency. So of course, we would not be able to see a hypotension and hyperpigmentation in secondary adrenal insufficiency. So secondary adrenal insufficiency is usually due to pituitary lesions, causing diminished ACTH secretion, and other causes would include long-term steroid therapy. Tertiary adrenal insufficiency is due to decrease in production of hypothalamic CRH. So as a result of decrease in CRH, there would be decrease in ACTH production, and there would also be decrease in cortisol production. Aldosterone is also not affected, so it's normal, and the androgens would also be decreased. And the usual cause for tertiary adrenal insufficiency is steroid withdrawal. So for the diagnosis of secondary adrenal insufficiency, of course, we should be able to document hypocortisolemia. So we should be able to see low cortisol levels plus low ACTH levels, so that we would be able to draw the relationship that the low cortisol levels is due to the low ACTH levels. Then we also do ACTH or cosintropin stimulation test. Cosintropin is a synthetic form of ACTH. So what we do is we first draw the baseline cortisol, then we give 250 micrograms cosintropin given intravenously, and then we determine the cortisol levels 30 minutes and 60 minutes after cosintropin is given. Now, if we are dealing with a primary adrenal insufficiency, there would be no response because, again, the defect in primary adrenal insufficiency is intrinsic to the adrenal gland itself, such that further increases in ACTH would actually have no effect on the production of cortisol. So there would be no response. Now, if we are dealing with a secondary adrenal insufficiency, then of course, since the defect is a decrease in ACTH, meaning to say giving ACTH would result to increase in production of cortisol. For the treatment, of course, the mainstay of treatment would be glucocorticoid replacement therapy. Now, this is for a secondary adrenal insufficiency. So total dose of hydrocortisone should be less than 20 milligrams per day, divided into 2 to 3 doses. We can also give prednisone 5 milligram each morning, which is longer acting and has fewer mineral corticoid effects compared to hydrocortisone. Lower maintenance doses leads to less Cushingoid side effects, and doses are increased during periods of acute illness or stress in order to compensate for the increased demand of the cortisol. So for the algorithm of the management, so of course, when we are faced with this clinical presentation, weight loss, fatigue, postural hypotension, and etc., then we should be able to suspect already adrenal insufficiency. Then we do confirmatory and screening tests. We measure cortisol levels and concentropin levels, and also we get the levels of plasma ACTH, plasma renin, and serum aldosterone. Now, if we are dealing with a primary adrenal insufficiency, then there should be high ACTH, high renin, and a low aldosterone. The high renin is due to the low aldosterone because since there is low aldosterone, renin would try to increase in order to, as an attempt to increase production of the aldosterone. So I will not go into detail anymore with regards to the primary adrenal insufficiency, but suffice to say, primary adrenal insufficiency is managed with glucocorticoid and mineralocorticoid replacement. Now, with regards to secondary adrenal insufficiency, of course, there should be low to normal ACTH, normal renin, and normal aldosterone, since again, aldosterone production is not affected. So the mainstay for the treatment would be glucocorticoid replacement. And with regards to the imaging, we can perform MRI of the pituitary gland, and then it would be positive if we would be able to identify hypothalamic pituitary mass lesion. Now, if there would be no lesion identifiable on imaging, then we should look for other probable causes, such as is there a history of exogenous glucocorticoid treatment? Is there a history of head trauma? And then we consider isolated ACTH deficiency. So that would be all for secondary adrenal insufficiency or ACTH deficiency. So any questions for my first topic? Doc? Okay, so I will proceed with my second topic, which is Cushing's. Sorry, bation pa ako, Doc?
Oo, bation ka. Ano lang ko what is the stress kundi you have patients who are on the prednisone 5 milligrams as their maintenance dose. So if a patient has any form of stress, how high can you give your prednisone during those times? Anong stress dose sa prednisone?
For prednisone, though,
para you can advise your patients. Maski sa ano lang sila sa balay, no, pwede sila take sang stress doses of prednisone. Tapos after the stress is gone, then you can go back to your maintenance dose of your prednisone. So usually it's around 15 milligrams.
15, okay. Thank you, Doc.
Thank you.
So for my second topic, which is about Cushing's disease. So my objectives for this discussion are as follows. First is to discuss the clinical features of Cushing's disease, then to differentiate Cushing's disease from Cushing syndrome and from ectopic ACTH production, and third is to discuss the laboratory evaluation and treatment of Cushing's disease. So first, it's important to define first important terms. So when we speak of Cushing syndrome, it reflects a constellation of clinical features that result from chronic exposure to excess glucocorticoids of any etiology. So take note of any etiology. So it can be due to an ACTH dependent it can be ACTH dependent, which is due to pituitary corticotrope adenoma, as in the case of Cushing's disease. So meaning to say Cushing's disease is actually a specific type under Cushing syndrome. Ectopic ACTH secretion by non-pituitary tumor, or it can also be ACTH independent, wherein the problem would probably be already on the adrenal. So there would be an adrenal mass, adrenocortical adenoma, adrenocortical carcinoma, or nodular adrenal hyperplasia, or it can be iatrogenic or drug-induced. When we speak of Cushing disease, this is an excess glucocorticoids due to pituitary corticotrope, or when we speak of corticotrope, it's an ACTH producing adenoma. So strictly speaking, meaning to say Cushing's disease is actually pituitary Cushing syndrome. So for the etiology and prevalence, iatrogenic hypercortisolism is the most common cause of Cushingoid features overall. Pituitary corticotrope adenomas account for 70% of patients with endogenous Cushing syndrome. ACTH producing adenomas account for 10 to 15% of all pituitary tumors, and most ACTH producing adenomas are relatively small microadenomas. Cushing's disease is 5 to 10 times more common in women than in men, and the important feature of pituitary adenomas is that there is unrestrained ACTH secretion with resultant hypercortisolemia. And pituitary adenomas retain partial suppressibility in the presence of high doses of glucocorticoids. This is what differentiates it from non-pituitary or ectopic ACTH producing tumors. So for the clinical features, of course, there will be Cushingoid features. So we should be able to identify thin skin, central obesity, hypertension, plethoric moon facies, purple striae, easy bruisability, glucose intolerance or diabetes mellitus, gonadal dysfunction. So there would be amenorrhea, impotence, osteoporosis, and proximal muscle weakness, which tend to affect the upper arm and the thighs. And then there will be signs of hyperandrogenism, such as acne and hirsutism. And oftentimes there would be psychological disturbances in the form of depression, mania, and psychosis. And there would often be hematologic derangements. So in the CBC, we should be able to look at leukocytosis, lymphopenia, and eosinopenia. And of course, immunosuppression, which is an effect of increased steroid levels. So this one, we have here the moon facies. Then we have this one, the buffalo hump. Then we have the purple striae and the easy bruisability. So all of this we should be able to identify in patients with Cushingoid features. So there would also be cardiac hypertrophy, amenorrhea, impotency, polyuria, and hyperkaluria, and osteoporosis. So the most common clinical sign of Cushing syndrome is obesity or weight gain and thin skin with an overall frequency of 80%. The primary cause of death is cardiovascular in Cushing syndrome, and life-threatening infections and risk of suicide are also increased. Next, we discuss the differences between... Yes, Doc? So next, we discuss the differences between adrenal Cushing, pituitary Cushing, or the Cushing's disease, and ectopic Cushing. So of course, since these are under the umbrella term Cushing syndrome, so of course there would be elevated cortisol. Now in adrenal Cushing, the primary defect is increase in cortisol production. So since there is an increase in cortisol already, ACTH would be decreased. And it is important to note that high-dose dexamethasone suppression test would actually have no effect, and corticotropin-releasing hormone stimulation would actually elicit no response if we are dealing with adrenal Cushing syndrome. So in summary, if that is an adrenal Cushing, then there should be hypercortisolism plus low ACTH in the setting of an adrenal mass. So meaning to say that the defect is on the adrenal mass. That's why it's called an adrenal Cushing. Now, if we are dealing with a pituitary Cushing or Cushing's disease, the primary defect would be the increase in ACTH production, And as a result of ACTH, increased ACTH production, there would be an increase in cortisol production. Now, what is an important characteristic of pituitary Cushing is the suppressibility to high-dose dexamethasone test, and there would be a response to CRH stimulation, positive response in the sense that there would be significantly increased ACTH and cortisol when we give CRH. So in summary, if we are dealing with a pituitary Cushing, there should be hypercortisolism plus high ACTH plus suppression by high dose DST plus a response to CRH stimulation in the background of pituitary adenoma. Now, if we are dealing with ectopic Cushing, similar to pituitary Cushing, there would also be increase in ACTH, and as a result of that, there would also be increase in cortisol. But the difference would be there would be no effect for high-dose dexamethasone suppression test, and CRH stimulation would also elicit no response if that would be an ectopic Cushing. Now, this is because in ectopic Cushing, we actually have a neuroendocrine mass which does not respond to the feedback mechanisms of the HPA axis. So there would be no effect and no response for CRH stimulation. So if that would be an ectopic Cushing, there would be hypercortisolism plus high ACTH. It would not be suppressed by high dose DST, and there would be no response to CRH stimulation, plus in the setting or in the background of a neuroendocrine mass located elsewhere. So rapid development of hypercortisolism, signs and symptoms associated with hyperpigmentation and severe myopathy suggests an ectopic source of ACTH. Hypertension, hypokalemic alkalosis, and glucose intolerance and edema are also more pronounced in ectopic Cushing's. Iatrogenic Cushing can be easily excluded by history. So here we have the differences between ACTH secreting pituitary hormone tumor and ectopic ACTH secretion. So usually ACTH is produced by a pituitary corticotrope adenoma or a plurihormonal adenoma in ACTH secreting pituitary tumor. While in an ectopic ACTH, we should be able to look at a probable bronchial, abdominal carcinoid, or a small cell lung CA or thymoma. With regards to the sex, ACTH secreting pituitary tumor is more common in female, while ectopic ACTH is more common in males. For the clinical features, as mentioned earlier, when there is rapid onset and there is marked hyperpigmentation and severe myopathy, then probably we're dealing with ectopic ACTH secretion. Now, we should also be able to note serum potassium of less than 3.3 or hypokalemia, which would be present in less than 10% only in ACTH secreting pituitary tumor, while it's present in 75% of ectopic ACTH secretion. Of course, urinary cortisol levels would be both high for both cases. Basal ACTH level would be inappropriately high for ACTH secreting tumor, while for very high if that would be an ectopic ACTH. Now, with regards to the dexamethasone suppression test, the low dose dexamethasone suppression would actually have no effect for both ACTH secreting pituitary tumor and for ectopic ACTH. So after giving a low dose, cortisol would still be more than 5 micrograms per deciliter for both cases. But if we give a high dose dexamethasone, if that would be an ACTH secreting pituitary tumor, then cortisol would be suppressed. So there would be decreased to less than 5. But if that is an ectopic ACTH, still there would be no response. So in the diagnosis of Cushing's disease, so step 1 is to clinical suspicion of Cushing's disease. Then step 2 is to document the hypercortisolism. Step 3 is to determine the cause of hypercortisolism. And step 4 is we do the imaging. So for the algorithm, so we have here So of course, when we encounter these signs and symptoms, so we should already suspect Cushing syndrome. And then we do screening and confirmation of diagnosis. So we do 24-hour urinary free cortisol excretion, and if it's increased above normal by about 3 times, then that will be positive. We can also do dexamethasone overnight test. A positive test would be a plasma cortisol of more than 50 at 8 to 9 a.m. after 1 milligram dexamethasone given at 11 p.m. the night before. And then midnight plasma cortisol of more than 130, or a midnight salivary cortisol of more than 5 nanomoles per liter. So if further confirmation is needed, then we can do low-dose dexamethasone test, a plasma cortisol of more than 50 after 0.5 milligram dexamethasone every 6 hours for 2 days would also be a positive test. So again, if we have any of this positive, then we proceed. So we measure the plasma ACTH, and then if that ACTH is normal or high at more than 15 picograms per ml, then we are dealing probably with an ACTH dependent Cushing's. So we do the imaging, we do the MRI of the pituitary gland, or we do the corticotropin releasing hormone test, wherein a positive test would be an ACTH increase by more than 40% at 15 to 30 minutes, plus a cortisol increase of more than 20% at 45 to 60 minutes after giving CRH of 100 micrograms IV. Then we can also do the high-dose dexamethasone test. And then if both the CRH test and high-dose dexamethasone test are positive, then we are dealing with a Cushing's disease. So if that's a Cushing's disease, then the mode of treatment would be transsphenoidal pituitary surgery. However, if we have equivocal results, then we proceed to performing inferior petrosal sinus sampling. So inferior petrosal sinus sampling is an invasive procedure in which ACTH levels are sampled from the veins that drain the pituitary gland. These levels are then compared with the ACTH levels in the peripheral blood to determine whether a pituitary tumor, as opposed to an ectopic source of ACTH, is responsible for ACTH-dependent Cushing syndrome. So what we do in inferior petrosal sinus sampling is it's done at baseline 2, 5, and 10 minutes after IV bovine corticotropin releasing hormone administration at a dose of 1 microgram per kilogram. So actually what we do here is we insert a catheter via the common femoral vein, and then we advance it to the inferior vena cava, then to the superior vena cava until we reach the jugular vein, and then going to the inferior petrosal sinus already, which is the major venous drainage of the pituitary. So we get there, we sample blood from there. Then how do we interpret? So an increased ratio of more than inferior petrosal to peripheral vein ACTH would confirm pituitary Cushing syndrome. A peak petrosal to peripheral ACTH ratios of 3 or more would also confirm the presence of pituitary ACTH secreting tumor. Inferior petrosal sinus sampling has a sensitivity of more than 95% with very rare false positive results. So of course, contraindications for this procedure would be hypertension, known cerebrovascular disease, presence of a well-visualized pituitary adenoma on MRI. So going back, so if there would be vocal results, then we perform the inferior petrosal sinus sampling. And then if that would be positive, then again, we do the surgery. And then if that would be negative, then probably we are dealing with an ectopic source of ACTH. So for going back to the plasma ACTH levels, if ACTH is suppressed to less than 5 picograms per ml, then probably we are dealing with an ACTH independent Cushing's syndrome. So meaning to say that the problem would probably be at the adrenal level. So we do CT scan of the adrenals. Then if there would be a bilateral micronodular or macronodular adrenal hyperplasia, then we do bilateral adrenalectomy. Or if there is a unilateral adrenal mass, then of course we do a unilateral adrenalectomy. So for the treatment, as mentioned earlier, selective transsphenoidal resection is the treatment of choice for Cushing's disease. There's a remission rate of 80% for microadenomas, but less than 50% for macroadenomas. Low-dose cortisol replacement may be required post-operatively as most patients experience symptomatic ACTH deficiency that may last up to 12 months. So if the initial surgery is unsuccessful, we have the following options. So we can do repeat surgery, which would be indicated, especially if a pituitary source has already been documented. Now, we can also do a hemi or total hypophysectomy, may be necessary if a discrete pituitary adenoma is not recognized. So we usually do this only for older patients wherein growth and fertility would not be an issue anymore. We can also do pituitary irradiation, but it only cures up to 15% of patients. Now, other options would be medical management for persistent hypercortisolism post-operatively in the form of pasireotide, ketoconazole, mifepristone, metirapone, mitotane, and other drugs. So first, we have pasireotide, which is a somatostatin analog with high affinity for somatostatin 5, more for somatostatin 5 than somatostatin 2 receptors. In clinical trials, this drug has been found to lower plasma ACTH levels and normalize 24-hour urinary cortisol levels in 20% of patients and resulted in up to 40% mean shrinkage of the pituitary tumor. We can also give ketoconazole, which is an antifungal, but in this context, it is used for its steroidogenesis inhibitor effects linked to inhibition of cytochrome P450 enzymes. At high concentrations, it acts as a glucocorticoid receptor antagonist. We can also give mifepristone, which is a glucocorticoid receptor antagonist, and hence it blocks peripheral cortisol action. It's also approved for treatment of hyperglycemia in Cushing's disease. And the ACTH and cortisol levels, however, would remain elevated because it does not target actually the levels of ACTH and cortisol levels. Next, we have metirapone and mitotane, which both inhibit 11-beta hydroxylase. So 11-beta hydroxylase is this enzyme. So if we block this enzyme, meaning to say we would block further production of cortisol. So metirapone inhibits 11-beta hydroxylase activity and normalizes plasma cortisol in up to 75% of patients, while mitotane suppresses cortisol secretion by inhibiting 11-beta hydroxylase and cholesterol side chain cleavage enzymes and by destroying adrenocortical cells. Next, we have bilateral adrenalectomy, wherein we do the surgical removal of both adrenal glands. This would correct hypercortisolism, but may be associated with significant morbidity rates and necessitates permanent glucocorticoid and mineralocorticoid replacement. Adrenalectomy in the setting of residual corticotrope adenoma tissue predisposes to the development of Nelson syndrome, which is a syndrome characterized by rapid pituitary tumor enlargement and increased pigmentation secondary to high ACTH levels. So in order to prevent the development of Nelson syndrome, we do prophylactic irradiation post-adrenalectomy. So that would be all for my two topics for this day. Any questions, doctors?
How many Cushing syndromes have we managed for the year or since last year?
Yung variant niya daw, kung tayo niya na lang sa yung sabi niya, para hindi na raw man. Tapos yung isa, pag-boards na ano na lang. Balito si Sir.
Wala masyado.
Hello, Doc. I'm not quite familiar pa, Doc. Kasi, bago lang kami, Doc, first year, Doc. So far, Doc, in the wards, I haven't encountered, Doc, a case of Cushing syndrome, Doc.
Okay.
Other questions, Doc? So since there would be no questions, let us proceed with the next speaker.
Anong next case? Dali lang ha. Can I be excused for 10 minutes? Dali lang din.
Yes, Doc.
Okay lang.
Yes, Doc.
Thank you.